We welcome you all for the day 2 of 5th Manipal International Infectious Disease Conference. To begin with our scientific sessions for the day, we have with us Dr. Kavitha Saravu, Dr. Anivita Aggrawal, Dr. Chandni R. I invite Dr. Ashwini Kumar, Professor and Head, Department of Community Medicine, KMC Manipal, and Dr. Jayaraj M. Balakrishnan, Professor and HOD, Department of Emergency Medicine, KMC Manipal, to chair the sessions.
Good morning, everybody. Welcome to the second day of the sessions. It's my proud honor to introduce Dr. Kavitha Saravu, my colleague and a KMC. Once I was a postgraduate here, I used to see a madam and I used to revere like the work she was doing in the ICUs with respect to infectious diseases. She was tenacious and she is a researcher of the great respect. And this center stands as an evidence for that. So she's a professor and head of the Department of Infectious Diseases, Kasturba Medical College, Manipal, and also serves as the center, as I said. She has clinical and research expertise in infectious diseases, especially malaria, melioidosis, TB, HIV, scrub typhus, and KFD. The last one mentions last two. She has done a lot of work with the emergency medicine department, which I have to recollect here. She is currently working on scrub typhus, tuberculosis, HIV, and malaria, for which she has received the funding from ICMO, DBT, Wellcome Trust, and SERB CRG. And she is the editorial board member of the BMC Infectious Diseases and PLOS Global Public Health. Welcome, ma'am.
Good morning. My topic is scrub typhus in India. So scrub typhus has been here and around the world for a long time, and it's re-emerging in certain parts of the world. Traditionally, it was confined to what is known as Tsutsugumushi Triangle, which encompasses southern and Southeast Asia. Just go to the next slide. And also the islands of Indian Ocean and Pacific Islands. But now we know that it is expanding beyond the Tsutsugumushi Triangle, and there have been cases from different parts such as South America, Chile, Peru, and also Dubai. There is one case reported from human even from Dubai. And so that means it's expanding its territories, and in different parts of it's being reported from different parts, and it's not confined to the traditional Tsutsugumushi Triangle. From India, it's been there for a long time, and it was not recognized in different parts for even about 1 decade ago. So there are this was a systematic review which was done and published recently, which looked at the data from 2010 to 2020 and from 138 hospitals, hospital based studies and 2 community based studies. The study showed that the proportion of scrub typhus in acute febrile patients, acute undifferentiated febrile illness patients, is up to 24%, and community seroprevalence, this is based on I think very highly endemic area, which is 34%. Sero surveys which was done just in 2 studies, which shows 34% seroprevalence with IgG against scrub typhus. And multi-organ dysfunction was present in 17% of patients, and fatality was in about 6.3%. And in patients with multi-organ dysfunction, the fatality was about 39%. So, as I said, there have been outbreaks in India. Multiple outbreaks are being reported, or it was being reported from even from 2005 onwards, or even before that. This is just the data which I could get it from IDSP program. So much so that, you know, in Gorakhpur, so there was multiple episodes. There were outbreaks of acute encephalitis syndrome being reported in Gorakhpur region. Year after year, with high mortality in children. So they went on investigating. In the initial years, it was attributed that it was episode of Japanese encephalitis. So what they did was, government and the local health authorities, they introduced Japanese encephalitis vaccine. So with that, the kind of these episodes or the magnitude of these outbreaks came down to certain extent, but it didn't disappear. Again, year after year it went on happening. So one such episode was investigated in 2016. What they did was they looked at the immunoglobulin levels against scrub typhus in those patients who recovered from those episode of encephalitis versus healthy controls. What they found was in this cohort they had high proportion of IgM and IgG. If you look at the chart A, the black color is the control. So the OD value against IgG and IgM both were very lower side in control groups, but in cases they had high OD values both for IgM and IgG. So that means there was a background the immunoglobulin against scrub typhus. So this is the first time they found that these episodes of encephalitis must be scrub typhus. And subsequently lot of investigations went in Gorakhpur. So once they realized these encephalitis syndromes are indeed about 60% due to scrub typhus, they went on to investigate what are the genotypes which are circulating in Gorakhpur, and it was found that it was CARP, Keto and TA678. So this was the circulating genotypes in Gorakhpur area. And also simultaneously some of the investigators looked at where are the patients getting this kind of encephalitis. So there must be some reservoirs. So in small animals they looked at the animal population and the mites which is on them, whether they have this Oriental Tsutsugamashi. So indeed they found that there were a lot of vectors and the reservoirs which are responsible for this encephalitis syndrome, and they also did case control studies and they proved that children who went out and were playing, and this is how they got this encephalitis. So there was they could prove the causation also. And then finally there was a review paper which summarized all these things in the encephalitis syndrome and the reservoirs, and they connected the dots. And also what they did was they did the intervention, and the government recommended azithromycin for all the patients with encephalitis as a first treatment, and with that they demonstrated the mortality came down significantly. So it is caused by Oriental Tsutsugamashi, the intracellular bacteria, and transmitted by the chiggers of the trombiculid mites. And so the episodic episodes of scrub typhus coincides with the density of this larvae or the chiggers. Whenever immediately after rains or during the dry season, when the density of these mites, the larval forms increases, the seasonal episodes of scrub typhus happens. There is also a rare incidence of vertical transmissions. So that is something which you have to be aware, and incubation period is about 6 to 21 days. So this is our data, our hospital data from 2019 to 2023. You can see that every year from September onwards we get scrub typhus until about February. So this has been going for the last few years, and this is in corroboration with data from others. So when the chigger bites, it will enter after inoculation, it will enter into the endothelial cells, and at the area of the inoculation in the skin there is a host response that results in a small ulcer and necrosis. So that is known as the host response. There will be a eschar which is formed, and also the regional lymphadenopathy, and once they are inside the endothelial cells within the cytoplasm they will multiply, and then by escaping the phagosome, and then it will disseminate to different organs. Again it will enter the endothelial cell. So basically it produces vasculitis at different organs. That is how it becomes a multi-organ involvement and a systemic disease. So this is a classical eschar at the area of the inoculation. So it depends on the host immune response as well. So that is why it is not present in everybody. It may be present in certain patients, and it can be anywhere from 5 to 20, and sometimes it is missed because we do not look for them and they are not obvious in the very visible areas of the body. There may be literature says there is definitely also there is a differences where they are found in males and females. One study reported that in males it was present in groin, genitalia and in axilla predominantly, and in females over the chest and abdomen. So, how do they present? It is mostly like acute febrile illness. It looks very much like typhoid and leptospirosis. You can see that fever. These are different clinical features between patients who succumbed and who recovered. If you look at the patients who recovered, there is fever, headache, myalgia, GI manifestations like vomiting, diarrhea also can be there. Some of the patients can have cough, breathlessness, and eschar was present in 13% of our population. And altered sensorium, because one of the important manifestation is encephalitis. So, altered sensorium can be present, or any form of sometimes seizure also can be present. It is generally present in about maximum 10 to 20% of patients. And the median duration of presentation to the hospital was 7 days from the onset of symptoms. However, they can have organ involvement and complications. Yeah. So, in the systematic review about 20% patients were complicated. So, the most common complications what we saw were cardiovascular and respiratory in about 24% of patients, and central nervous system 5%, hematological thrombocytopenia was in about 7%, renal and hepatic complications. These are all the presenting symptoms and the complications. So, what about pregnancy? So, this is the biggest publication which I could get, 33 patients from Chennai, Vellore. So, it is quite bad. The prognosis in pregnancy with scrub typhus was bad as per this paper. If you can see the first trimester and the first trimester fetal outcomes, in good fetal outcome was only in one case out of 5, and in third trimester out of 19 the good fetal outcome was only in 7. Similarly, maternal outcome also there were organ dysfunctions, but more importantly the outcome, fetal outcome. If an infection happened in pregnancy, you can see that poor fetal outcome was in 51% of pregnancies, and predominantly it was fetal loss, and so it was all the patients were treated with azithromycin. So, this is something to remember. These days we should be concentrating more on non-torch infections like dengue, chikungunya and even scrub typhus during pregnancy. They are more prevalent and we should be giving more attention to those kinds. And neonatal scrub typhus. So, there are a lot of patients are being reported these days. This was a series of 5 patients where you can even see they present with rash in children, hepatosplenomegaly and breathlessness, sepsis. The neonatologists or the pediatricians might not think of it and might not get enough time. Sometimes they have eschars also, but importantly if they received doxycycline they have recovered. In this series only one death was there up to 20%, but other 4 recovered on doxycycline. Also there are reports of congenital scrub typhus, means mothers having illness in the towards later during pregnancy, and the newborn also had something similar illness in some forms like a febrile illness, shock, all these things. So, in literature there is about 8 to 10 cases of congenital scrub typhus. This is something what we should be aware of. Again some of the patients were given azithromycin, some were given doxycycline. So, doxycycline can be given in this situation. So, as you can see it is like many of the acute tropical febrile illnesses, like resembles very closely typhoid, that is the name of typhoid has come from similarity to typhus, and definitely other rickettsial illnesses. We should be worried about, we should be also thinking about leptospirosis in the relevant season, arboviral infections. In encephalitis patients you will always think of herpes and Japanese encephalitis. dengue of course and malaria is receding. So, other rickettsial illnesses, they look similar and we often do not have diagnostics. So, maybe we are not making a diagnosis of other rickettsial infections, and just to give a major important difference, what I can say is that they look similar clinically, it is not possible to say for sure, but eschar is more common in scrub typhus and maculopapular rash is more common in spotted fever group. So, coming to the diagnostics, we have diagnostics are not available everywhere, but we have different levels, different types of tests with different sensitivities. We have IgM test, which is a rapid screening test which can detect both IgM and IgG, and immunochromatographic test. Enzyme and most commonly what is employed is IgM ELISA, which can detect both IgM and IgG. ELISA are available, but IgM ELISA is used for diagnostic. Wheel-Felix test, I will come to it, and the confirmatory tests are PCR, immunofluorescence assays. So, the Wheel-Felix test is heterophile antibody test, and it depends on sharing of the antigens between rickettsia and proteus. And I just want to show you that the sensitivity is poor, 15%. However, it has got a good specificity of 96%. So, that is something to remember. If some people do not have any test, it is good test for the children, okay, because the background positivity may not be so much. So, pediatricians oftentimes use this test. Specificity is good, but sensitivity is poor. And immunofluorescence test, so this is kind of a little bit difficult to perform, but and also in our comparison it has not performed as good as the IgM ELISA, but it is considered a confirmatory test and accuracy is about 84%. This was a paper which looked at different available diagnostics, and they looked at scrub typhus patients versus other tropical febrile illness patients, and they looked at the sensitivity and specificity. As you can see, out of the rapid test, ImmuneMed had the best performance when compared to InBios and SD Bioline, and Wheel-Felix, as I said, specificity was good, and the PCR test, real time PCR was with the 47 kilodalton gene target they had used, that was the best according to this paper, and IgM ELISA had around above 90% sensitivity and specificity. So, what is the problem with the most commonly available and used test? Because we all go by IgM ELISA, and in the systematic review we found that about 90% of the cases, in all of the cases in India, were diagnosed based on IgM ELISA. So, we looked at what happens to patients with scrub typhus after recovery, and we saw that IgM ELISA, it was all high at the beginning, and the blue color is IgM, and it persisted up to most of the times it persisted in high levels up to 3 months, then it started decreasing over time, and IgG, it reached its peak during 12 months and it stayed high later. So, this was one of our patients whom we could follow up throughout for about 1.5 years. This is, you can see how the lab cutoff is 1 for IgM OD value, and you can see that IgM and IgG persisted. IgG persisting is fine, but if IgM is persisting for long time and that is our diagnostic, what will happen if a patient comes to you with fever even after 6 months, after 1 year, and you do IgM ELISA and you diagnose scrub typhus? It is possible that it is the IgM which is remaining from the previous infection, and the current infection may be something totally different, that we should be well aware of whenever we are using IgM based diagnostic for any of the febrile illnesses. It may be there from the previous infection. So, this was the proportion of patients who had that persistence, and 50% of our patient had IgM value above the cutoff at 9 to 12 months. That is the message I want to give you. 50% had above the cutoff. So the genotypes and also some of the complications might be based on the genotypes, and the circulating genotypes in India are all as above listed here, and this is the genotype which is circulating in Karnataka based on our study. We had Gilliam and Japanese Gilliam variant and carp. This Japanese Gilliam variant were the predominant circulating genotypes in Karnataka, and we do not have good data to say which genotypes are responsible for which type of phenotype. Maybe multiple centers, when they do the studies, individual patient data analysis might be helpful to give the correct picture. So the patients present with fever on fatigue of 10 days, one of the patients, that is an example, and he had an eschar on the chest, and he had hypoxia on room air, and echocardiogram showed globally hypokinetic LV. Sometimes myocarditis is one of the complications, and troponin was elevated. You can see the platelet was low, and his liver functions and renal functions were all abnormal. Chest X-ray was also abnormal. This is one of the complicated cases what we typically see in scrub typhus, and we did all the febrile illness workup, even the rickettsial screening with immunofluorescence test for different types of spotted fever and typhus group. And in this patient, the scrub typhus IgM ELISA was positive, and the PCR was positive for 56 kilodalton gene target, and genotype, it was a carp genotype. So we found that carp is associated more with cardiorespiratory problems, and he improved with treatment what we administered. Another patient, fever, chills 8 days, headache, myalgia, vomiting since 6 days, and he had developed a GTCS outside, and he was shifted or referred to our hospital. At admission he had a poor GCS, I mean GCS was 13, he had meningeal signs, and we thought this is one of the cases of meningoencephalitis, and empirically we started ceftriaxone and doxycycline. You can see the lab values there, and this patient had IgM scrub typhus positive, and again PCR confirmed, and the genotype was Japanese Gilliam variant. Again this patient improved, he was given doxycycline, and on recovery we found that bulbar palsy which persisted for some time, but finally he improved and he recovered completely. So when looking at the genotype and phenotype correlation, we found that hematological, renal and hepatic manifestations were more common with Japanese Gilliam variant, and the carp was associated more with cardiovascular and respiratory manifestations, but we can't be very sure about the certainty will be less because of the numbers. So I would like to just highlight on one of our study where we were one of the sites in India which looked at what is the best treatment for severe scrub typhus. So that is the intravenous treatment for severe scrub typhus, it is known as INTEREST trial. So multi-center randomized double blind study where there was a 3-arm, where the one arm was treated with doxycycline, another with azithromycin intravenous, and the third arm had a combination of azithromycin and doxycycline. Patients were who were older than 15 years, and they were screened using the rapid diagnostic test from the emergency and emergency department, and the severity was predefined. So the patients who were enrolled, they had respiratory, hepatic, cardiovascular, renal and neurological involvement with varying proportions. So what the composite outcome of 28-day death, persistent complications at day 7 and persisting fever at day 5 were the primary outcome. And what we found was the combination therapy was better than azithromycin or doxycycline alone. You can see that combination therapy, the events happened in 33, and doxycycline, these primary composite outcomes happened in 47 and 48 cases. So the combination therapy was better as with reference to the composite primary outcome. And the key secondary outcome, like the survival or the mortality, 28-day mortality, there was no difference. Persistence of fever, there was no difference between these arms. And so the whole thing of primary composite outcome was driven by the persisting complications at day 7. So what I want you to look at is what were these persisting complications. It was cardiovascular complication, respiratory complication, CNS complication, renal and hepatic persisting at day 7. So this was the risk difference between the two groups. Monotherapy, so this is driven mainly by persisting complications, respiratory involvement at day 7 and also the hepatic involvement. Respiratory involvement meaning patients who required ventilation or patients who required oxygen support at day 7. So there was a difference, major difference by this. Of course, hepatic component also contributed, also to certain extent renal involvement. So these were the points which tilted the study towards combination of azithromycin and doxycycline. And there was PCR positivity. If you look at the PCR became negative faster in any arm which contained azithromycin as opposed to doxycycline. And with reference to grade 3 adverse event, there was no difference between these arms. So as per this study, the best treatment for severe scrub typhus is a combination of azithromycin and doxycycline. And there was a systematic review from Nitin subsequent to this subsequent to the interest trial, where he looked at various published literature. There were 10 studies almost in this publication, which was randomized control trial. And while for mild scrub typhus, 3 days of azithromycin was equivalent to 5 to 7 days of doxycycline. For severe scrub typhus, what the study found, systematic review found was there was a shorter defervescence time with doxycycline. However, there was no difference between two arms, either doxycycline or azithromycin with reference to clinical failure, mortality or treatment, and there was no sufficient studies to have a combination of azithromycin and doxycycline in this systematic review. And out of the 10 studies which was picked up in the systematic review, most of the studies had a high risk of bias except the interest trial. One more thing I want to add is that we all, it's ingrained in our mind that doxycycline has, or the tetracycline group cannot be given in children because of the fear of staining of the teeth and the bone problems. But it's mostly with the older tetracycline, and there is no data to say that this same problem exists with doxycycline. So doxycycline, there should not be any hesitation to use doxycycline in children, even in children. So doxycycline is the drug of choice for rickettsial diseases in all age group. So we should feel free to use doxycycline, and it saves lives. And also as I showed, the data with azithromycin in pregnancy was poor, 50% poor outcome. So it's time that we take up doxycycline as a treatment for even pregnancy, scrub typhus or any rickettsial infections during pregnancy. And to reiterate, scrub typhus is one of the most important treatable causes of acute undifferentiated febrile illness other than malaria, and diagnostics are poor in early phase of illness. So because PCR we might miss, and IgM PCR is not available, IgM takes time. So if at all you have suspicion of scrub typhus, you should start treatment immediately, even before waiting for the diagnosis. And do not hesitate to use doxycycline even in children, pregnant women. And as of now, the combination of azithromycin and doxycycline is a preferred treatment. However, there is a scope for a good RCT again, because the severity criteria, it was expert opinion based. So we can have a better demonstrated or with a good scoring system, develop a severity criteria, and that can be used to compare different arms. Thank you very much.
For a beautiful clinico-epidemiological presentation of the disease. Audience, any clarification, any questions, any discussion, any suggestion points, please?
Azithromycin, what was the arrhythmias and QTC prolongation and all seen? Because many times these patients have underlying myocarditis and all. So using a QTC prolonging drug with in this combination in those patients, how is it?
Yeah. So the patients who have known arrhythmias, they were excluded from the study. Yeah, the patients who have known pre-existing heart disease, known arrhythmias were excluded from the study. But if it is a new onset, then you can correct the correctable factors. You can start with doxycycline and correct the correctable factors, then make sure the QTC is normal, then you can administer azithromycin.
Case where brainstem involvement without reversing. So what could be the mechanism of that brainstem? Is it something inflammatory or vascular?
So it looks like it is vascular involvement, because we see with many of the febrile illnesses with endothelial dysfunctions. So the vasculitis is known complication. So looks like it's a vasculitis which is given rise to that. And also now is an extension to this study, in certain population, especially with ARDS, we are also thinking of doing a study with whether the addition of steroid will have a role in decreasing the mortality further. So maybe there is a role in certain populations with a few of the clinical features. If it is persisting, then there may be a role for steroids as well.
Interest trial, what you mentioned.
Yes.
I think all the cases were diagnosed and then treatment started.
Yes.
Suppose if you suspect and from the day one if you start, do you think it will be the same response or the natural course will run and?
Sir, actually many of the, we did not exclude patients in whom azithromycin or doxycycline was given for less than 1 day. That's important. So many of the patients and many of the physicians administer IV azithromycin or doxycycline even on suspicion, which is the right thing to do. So I think we should not wait for diagnosis. Whenever you are even thinking of acute febrile illness, first is to rule out dengue, because it's very easy to rule out dengue with the existing diagnostics, malaria. So as long as we rule out diagnosis of dengue and malaria in acute tropical febrile illnesses, I think we should, if the end is a reasonable differential diagnosis is scrub typhus, leptospirosis, we should start the treatment then and there. And if possible, we should use point of care diagnostics to test for scrub typhus, which is very good. So, and also leptospirosis, we have point of care diagnostics. We should be using more and more point of care diagnostics.
Thank you.
To reduce the unwanted antibiotic use.
Thanks for wonderful lecture. Regarding as the question you asked, azithromycin, those who got a QT prolongations initially only will be scared to use IV azithromycin because of the cardiac deaths. Myocarditis patients, sudden deaths are also known to occur. Second thing is meningoencephalitis. That case may be vasculitis.
Yes.
Meningoencephalitis as such due to scrub typhus, is the chloromycetin is the better drug for the central nervous system penetration. That's what I read, and I have treated one patient who was in deep coma, proved scrub typhus. She improved. I have used chloromycetin, but it's very once only I have used, but patient improved, proved CSF scrub meningitis.
Yeah, so the interest trial did not exclude patients of meningoencephalitis, which is a good thing. And we had about 20% of the patients, 10 to 20% of patients with the neurological manifestation. And in this study, there were no other additional drugs given. For example, chloramphenicol, they were all contraindicated, concomitant medications. So the data says that even in these patients, the combination of azithromycin and doxycycline did very well.
CNS penetration of doxycycline and azithromycin. In terms of CNS penetration for meninges, I think chloramphenicol is got a better penetration, and
So-
it's a not used drug commonly because of the aplastic anemia.
Yes.
So it's almost outdated drug, and probably it is highly sensitive for scrub typhus also, I feel.
Yes,
But
it
we
is.
don't use it as a routine. Except probably I have used it for only meningitis, 1 or 2 cases I have used.
Yeah, but as per our experience also, we have seen the scrub meningitis improves like this. Like in 2 days you can see that they respond to doxycycline and azithromycin. So I think we should use this doxycycline and azithromycin. Azithromycin CNS penetration is good, and doxycycline it may not be great. So when you combine this azithromycin and doxycycline even in interest trial and even our experience, the scrub meningitis patients improve very well. So I think you should take it up. If in case you are not able to give azithromycin, maybe you should consider other medicines. For example, chloramphenicol is a good choice in other patients, but we don't have a data particularly in big number of patients with meningoencephalitis.
How soon the PCR will become negative after treatment?
Yeah, so the this data showed at about day 7, most of the patients who had azithromycin in their arm, they became negative, most of them. So it can persist a bit longer, but then azithromycin group had a shorter time to PCR negativity. And that's not a follow-up test anyways. We should not be worried about PCR positivity, persisting PCR positivity.
Yeah, anybody else? Yeah, I have a small question. No, you are repeatedly telling that this is endemic area here for dengue, malaria, leptospirosis and cephalitis cases. Is there any protocol, particularly in resource limited settings, to be followed for diagnosis and initial management? Is there any such things there in our facility, or do you recommend or suggest any such things for at least for resource limited settings, hospitals where you don't have all the facilities what we are enjoying here?
Yeah, so the acute tropical febrile illnesses, they vary with season. So epidemiological history, exposure history, all these things if you consider, your differential diagnosis vary with season basically. And taking that into consideration, as I said, if there is an area where there is malaria season, definitely you will rule out malaria and dengue, and because they are easy to diagnose and you can give specific treatment. And after that, whenever there is the other considerations, influenza, sometimes we will have to definitely think with the respiratory symptoms if they are there. Otherwise, definitely a combination of ceftriaxone with doxycycline to be started. And we have to evaluate for the tropical febrile illnesses, including, again we can repeat samples for malaria and send specific tests for dengue and leptospirosis, scrub typhus, and based on the positivity you can reduce the antibiotics.
Yeah, another thing.
So we would like to come up with that algorithm. Of course, there are in the literature some of them are present. But we will also try to do it for our setting.
Particularly, I am thinking of government hospital. Patient goes to limited settings there.
And CRP has got a good useful test. If the CRP is high, you obviously think of bacterial infections, and if CRP is low, then the high index for the viral infections. And also the CBP will be helpful. Most of the tropical febrile illnesses will have thrombocytopenia and maybe normal leukocytes or leukopenia. So these are some useful clues.
Hematological thing.
Yes.
Another interesting thing, I just wanted to know, you have seen so many cases, at what proportions the patients comes with that so-called cardinal features of scars? Scars.
Yeah, so the SCAR could vary in different populations studied depending upon the background immunity and also maybe the infecting genotype. So it could vary, and also the experience of the clinicians. If you look for it, you might get. So it could vary anywhere from 10 to 50%.
Thorough clinical and body examination is very important.
And also it's not that SCAR is like, it looks just like the black thing. At varying intervals of the evolution of the disease, SCARs could look differently. So that is something we have to be aware of.
Anything you want to ask?
You have done a thorough work on the KFD also. So if you're looking at it, it was interesting to see that our scrub season is slowly ending towards February, and your KFD season is starting.
Yes.
So it was very, very interesting to see that you will have this seasonal diagnosis. But don't you think that every institution should be, institution of this size or a referral institution should be having a protocol which is key to the local protocols which cannot be applied across the country?
Yeah, so I'm happy to say that one of the seed grant awardees is looking at that, developing a protocol for acute tropical febrile illness. Yeah. So we are looking at it. We'll come up with that.
Thank you.
Thank you, madam. We will now invite our second speaker, Dr. Anivita Aggrawal. She is infectious disease consultant from AIMS Delhi. Her area of interest is HIV, TB, and vaccines and vaccine studies. But today she is going to talk about Trematodes problem in India. That's one of the other neglected tropical disease. To tell a little more about her, she has done so many publications, research and all that. She is also a member of European Society of Clinical Microbiology and Infectious Disease, member of Infectious Disease Society of America, member of Clinical Infectious Disease Society in India. Madam, we would love to hear about the problem of these trematodes again in India and trends emerging or different types. We heard there are so many types of commensals like trematodes exists in human body. Over to your stage, ma'am.
Good morning, everybody. Thank you for inviting me for this lovely conference here. So I shall be discussing trematodes in India. This is not merely just a chapter in our textbooks. It's not as rare as it seems, and I would like to take you through a few interesting cases that I have seen recently to emphasize on how easy to detect, but with high index of clinical suspicion, we can actually find out these challenging trematodes. So what are exactly trematodes? Trematodes are liver flukes, intestinal flukes, lung flukes, and blood flukes. So amongst the liver flukes, we have Fasciola hepatica, we have Clonorchis, Opisthoarchis, which are essentially important for cholangiocarcinomas. We have intestinal flukes and we have lung flukes, which is paragonymous, and we have blood flukes. Due to shortage of time, I shall be restricting on just a few of them. But to broadly give you an overview, this was the WHO survey from 2010 to 2014, which depicted that trematodes are widely spread out, mostly in the Southeast Asian region, and India harbors all four intestinal, liver and lung flukes, that is the foodborne flukes. Hence, they are known as the neglected tropical diseases, as they are difficult to detect and they are often missed. So starting from a case, now this was a 50-year-old female. She was a resident of Kanpur. She presented with 1.5 years of diffuse dull aching pain in abdomen, for which she used to be taking multiple painkillers. This was more in the right upper quadrant and it was non-radiating. She also happened to have certain facial rashes, for which she was going to a dermatologist and getting treated for acne, and she was taking multiple anti-allergic medications and steroidal creams for the same. She did not have any other features. She did not have fever or constitutional features. She did not have any history of melena or any other decompensated liver disease. On examination, this patient was having mild pallor. She had these erythematous pruritic rashes on her face, and she had right hypochondrium tenderness on deep palpation. She also had a slight hepatomegaly. Other than that, her rest of the systemic examination was within normal limits. Here, with these complaints, she presented to a local hospital where an initial basic blood workup was done and an ultrasound abdomen was performed. As you can see, the liver enzymes are fairly normal, apart from an ALP being slightly elevated, and she had hemoglobin of 10.2. This ultrasound abdomen image was reported as a multiseptate hypoechoic lesion, which was large, and the patient was referred to a higher center to be evaluated for probably a sol in the liver, and hence an alpha-fetoprotein was done. However, that was normal. So in view of further evaluation, she was suggested that a triple phase CT should be done. Here, hepatomegaly was detected, and there were multiple large peripheral enhancing lesions from segment 5 to segment 8 in the liver, as well as in the caudate lobe. And a few of the lesions were actually abutting the portal vein, and it was reported as query Mets. With this fearful report, she further got referred to another higher center, and she was advised a liver biopsy. So she underwent an ultrasound-guided liver biopsy, where it was suggestive of a eosinophilic granulomatous inflammation. Now the clinician got confused, and an infectious disease consultation was sent at this particular point of time. On reviewing the case, on taking detailed history, it was found that the patient had a dog for 10 years and he had died recently in the last 1 year. And around the same time, the patient had started to observe those pain abdomen and those vague complaints. Other than that, she had history of eating water chestnut. She was so fond of singhadas that she would eat kgs and kgs of singhadas every day. This was something that she was very proud of initially. So on reviewing that CBC that was initially sent out at the local hospital, we also found out that she had high amount of eosinophilia, which was missed by the initial at the initial visit. So this was to the tune of 25%. This was something very high. We got the CT scan reviewed. Now here we can see that there were, as you can, so you can see that we have hepatomegaly. These are these large multiloculated cystic lesions. They have some amount of peripheral enhancement, and there were these intervening heterogeneously enhanced parenchyma. There was a lot of edema in between these cysts. So these were clearly not a single lesion. These were multiple lesions which were separated by parenchyma edema. On reviewing the liver biopsy, there were also additional to the eosinophilic granulomatous inflammation, there were charcot-laden crystals that were characteristically present, and there was some amount of periportal fibrosis that was seen in the liver biopsy. So further to evaluate, we suspected visceral lava migrans, we suspected a strong epidemiological history, and we started getting serologies done for her. So Toxocara serology that was sent to AIIMS, that was negative. We reviewed her stool oocyst parasites in consecutive samples. Those did not reveal anything. Strongyloides serology was also done for completion. That was also negative. After discussing with my ID colleagues and seniors, we went ahead with Fishola serology that was sent to Izzatnagar in UP on special request, and Fishola serology turned out to be positive. So let us review Fishola. So this is reported in more than 70 countries all across the world, specifically in Middle East and in Southeast Asian region. However, the data is very, very scarce. I could barely find a few case reports here and there depicting the exact epidemiology of this particular disease. In India, if we look, it totally depends on the intermediate host. The presence of certain snails is what determines the epidemiology. So, and also the seasonal variations are according to the high rainfall areas or the floodplains or highly irrigated areas, specifically in the northeast and the regions of Uttar Pradesh and in the regions of even Mumbai, Bihar, where we have rice paddy fields, where we have these snail populations being high is where it is found. So Gigantica is more prevalent in India as compared to Fishola hepatica, and few case reports were even reported from Kashmir recently. So Assam, UP, Bihar, Mumbai, and some reports from Kashmir have been seen in India. In cattle, it is as highly prevalent as even 94% in certain areas who are grazing through these wild fields. So if we review the life cycle, the eggs are actually excreted out into the water fields where these eggs get embryonated, where the Miracerdium is entering the snail. Inside the snail, they go through the various stages of asexual reproduction, and they release metacercaria. They release cercarias. These free-living cercarias latch on to the water plants, form metacercaria, which is the infective stage. The water plants such as watercress, which is known as panifal, water chestnut such as singhadas, and other plants that are growing in the wild rather than the harvested or the cultivated water plants is what is the infective form for humans as well as from the cattle. They after ingestion, they latch on to our duodenum, they get excisted, and they travel through our biliary tracts. So the outbreaks have been reported where there is high amount of consumption of wild watercress and water chestnut, and often the contamination of drinking water in such areas is also very prevalent, and the cooking utensils often end up having certain amount of infective metacercaria, because of which poor sanitation is also an additional risk factor. So going through the cardinal features or the clinical features, we have an acute phase and we have a chronic phase. In the acute phase, the migration of this immature flukes is what is causing the destruction. So initial 1 to 3 months is the acute phase where the parasite is traveling through a biliary tract, causing death, causing inflammation, and releasing a lot of eosinophils. So the patient will be presenting with simple hepatosplenomegaly, certain amount of constitutional symptoms, and high amount of eosinophilia with elevated inflammatory markers. The chronic phase will be when the parasite has actually latched onto the biliary tracts and starts to lay eggs. Here, there will be features suggestive of mechanical obstruction because of the biliary ducts being actually obstructed by these eggs. So there is going to be features of cholangitis, cholecystitis, pancreatitis, and even further leading to cirrhosis and hepatic fibrosis. Here, the eosinophilia might not be a marked feature, but there will be anemia, transaminitis, and this stage will be more difficult to diagnose. So, simple constitutional symptoms, fever, and additionally a radiological and a pathological characteristic feature is what we need to look at. So, linear lesions with eosinophilia in a biopsy with Charcot-Leyden crystals suggestive of a eosinophilic granuloma is the characteristic feature of fasciola. On radiological imaging, we can find multiple clustered hyperdense lesions with perilesional edemas, with peripheral contrast enhancement and dilated biliary tracts and some amount of periportal tracking or periportal thickening. So these are the characteristic radiological features which one must keep in mind. In diagnosis, if we are if we've crossed the acute phase, it will be difficult to detect. However, stool is the primary diagnostic modality. So stool for ovocyst parasite is what needs to be done. This is the gold standard. There have been case reports where ERCP has been done for biliary fibrosis and where duodenal aspirate has been a good sample for finding out these eggs. Also, the mature flukes have been actually aspirated out from ERCP biliary sampling in few case reports that I saw. Other than that, ELISA is a good modality which has excellent sensitivity. However, there is limited availability of fasciola ELISA. So Izzat Nagar is one such place that I know of where fasciola sampling is done and it was very promptly reported within 4 to 5 days. However, there is cross-reactivity with the other trematodes. So what is the treatment modality? The treatment of choice is triclabendazole. So there are various dosing regimes that are there. One is 10 mg per kg single dose or 10 mg per kg divided in 2 doses 12 hours apart, that is 5 mg per kg. This is very well tolerated in adults as well as in pediatric patients. The other dosing regime which has shown very high cure rates is 20 mg per kg, that is 10 mg per kg given on day 1 and 10 mg per kg given on day 3. This had cure rates of more than 90 to 100% as per the reports. The absorption is good with a fatty meal. However, if we are in the chronic phase, the death of these parasites in biliary tracts can actually lead to obstruction. So this is something that needs to be monitored. Also, there are increasing case reports of drug resistance that is being found to triclabendazole. The alternative treatment is nitazoxanide that is freely available. So showing very few cure rates to 60%. 500 mg twice a day for 7 to 14 days can be tried in these patients. So coming back to our patient, we started off nitazoxanide. We gave her nitazoxanide for 14 days. Meanwhile, we requested the WHO headquarters at Geneva for availability of triclabendazole. Within a week, that was delivered at the doorstep of the patient, and we gave a course of 5 mg per kg twice. With 2 dose regime, that is 10 mg per kg split in twice daily, once and after 3rd day. So this was the triclabendazole that was delivered to the patient. After which, if we look at the eosinophilic count of the patient in August at the index presentation time, her eosinophilia was 25%. In September, while she was still undergoing the evaluation, it was varying to 14%. After receiving nitazoxanide and triclabendazole, at the end of 3 months, it is reduced to 5%. If we look at the radiological resolution, the first image is after treatment, the second image is before treatment. So if we can see that the cystic lesions have reduced in number, they've reduced in size, the perilesional edema has drastically reduced. The patient is asymptomatic, she's not having abdominal pain, her facial rashes have reduced, and she's comfortable. Coming on to our next case, this is a 6-year-old boy. He is a resident of Mizoram and he presented to pediatrics with history of 15 days fever with urticaria, productive cough with occasional streaky hemoptysis, pruritic type of chest pain and on and off joint pains. In a local clinic, he was found to have hypereosinophilia. of 55% with absolute eosinophil count of 9,500. This scared the pediatrician in Mizoram, and he was referred to a hematologist in Delhi. He was suspected to have hematological malignancies. On initial workup, this was the CT scan which showed ground glassing opacities and some cystic lesions in the left upper lobe. A bone marrow biopsy was done to rule out hypereosinophilia syndrome. Eosinophilic molecular panel was done, and an extensive workup was done for this patient. Stool microscopy did not reveal any overcyst parasite. After seeing the CT scan, the patient underwent a bronchoscopy. On BAL, AFB gene expert was negative, routine blood culture, bacterial and fungal cultures were negative, and overcyst parasites continued to be negative for this patient. The imaging was further reviewed, and it was found that there were these curvilinear opacities in the right upper lobe. Additionally, there were ground glass opacities, and these curvilinear opacities were predominantly in right upper lobe, and some amount was also there in the liver, in the segment 7 of the liver. Suspecting visceral lava migrants, further history was taken, and it was revealed that the patient was eating raw seafood. The whole family was very fond of eating raw seafood, and specifically this kid would go on fishing with his family and eat whatever would come out of the pond. Serological tests were sent. Everything turned out to be negative for Toxocara strongis, Toxoplasma, Echinococcus, and empirically the patient was given a big box of all antiparasitic agents, additionally with antibiotics, with steroids, and he was counseled for good food habits, and he was discharged. On further follow-up, his symptomatic resolution was achieved and eosinophilia had reduced. So something definitely worked, but what exactly happened with the patient was not clear. 6 months later, he again complains with the same thing. He again has fever, he again has blood tint sputum, and he again has hypereosinophilia to 34% this time. Confused, an ID referral was sent. At this point, history was reviewed again. So the family very categorically said that after your counseling, we made sure that the kid does not have raw seafood, but the family continued to have raw seafood. So the family was sharing the food utensils with the kid, and they were continuing to go on for their fishing sprees. The kid was accompanying them. However, he was not eating uncooked food. On examination this time, the patient had a 2 centimeter nodule in the middle aspect of the thigh, which was mildly mobile, which was non-tender, and CT scan was repeated. So 6 months from the previous imaging, if we review the CT scan, there was appearance of these new curvilinear lesions in the liver. These were near the subcapsular area, and there was partial resolution of the previous lung findings. So now the family was disappointed, the family was disheartened, decided to go back to Mizoram, and did not want further treatment or further hospitalization. Zoram Medical College, which was approximately 50 kilometers from their residential area, was contacted, and microbiology department was requested for stool sampling and sputum sampling for this patient. Stool sample revealed large operculated eggs on multiple samples, and the sputum sample did not reveal so. So here we have a patient who has features suggestive of Paragonimus, who was treated once and developed it again. So let us review Paragonimus species. So we are aware that there are around 16 species that affect humans and known as Oriental lung fluke. It is very common in the northeastern area, specifically in the rural and the hilly areas. Paragonimus species have also been specifically characterized as a species, subspecies manipuralis, because of high endemicity in the northeast. Co-endemicity with tuberculosis is one of the difficult features, as blood tint sputum with cough and expectoration is one of the cardinal features of Paragonimus, making it misdiagnosed as tuberculosis and being empirically treated as tuberculosis. So hence there's a lot of underreporting of this particular disease. If we go through the life cycle, this was, I recall it to be one of the most interesting life cycles that we used to read in parasitology, going through 2 intermediate hosts and the parasite traversing through so if we start from the life cycle, the embryonic eggs are what are floating into the fresh waters. Then the miracidium hatches out and penetrates the snail. This is our first intermediate host. From the snail, it goes through various cycles of asexual reproduction, after which cercaria are released. These cercarias latch on to further crustaceans, such as crabs, such as crayfish. Here, they further get encysted and form metacercaria. This is the infective form. Metacercaria are ingested by eating raw crustaceans. So then it goes and gets encysted into the duodenum. From the duodenum, it penetrates the peritoneum. It penetrates, goes into the liver, penetrates further, goes into the pleural cavity, and ultimately goes into the lung. In the lung parenchyma, in the lung, it ends up laying its eggs. It sits there, causes a lot of destruction, lays its egg, and the eggs are coughed out in sputum. The sputum gets re-swallowed by the human adult. After re-swallowing, the eggs are excreted into the stool. So this is one of the most interesting life cycles. However, what is important for us to understand is that not just eating undercooked seafood, but also the utensils is what is harboring the metacercaria, the infective stage. And if the utensils are not properly washed, the poor sanitation techniques in that family is what was leading to repeated infections to that kid. So what are the basic clinical features? The clinical features are essentially dependent upon the traversing or the path, the migratory path of the fluke. So it can range from asymptomatic to subacute to chronic infections depending on where the parasite is harboring. So what are the pulmonary manifestations? These are simple fever, malaise, diarrhea, pleuritic type of chest pain because it can cause reactive pleural effusion. Recurrent blood thin sputum, recurrent hemoptysis is characteristic. Additionally, there are extrapulmonary paragonomosis. This is something that we must be very careful in depicting. So the child had this slight nodule, the subcutaneous nodule in the thigh. This is very commonly reported to the tune of almost 44% amongst the children of Manipur, where the aberrant migrations of these juvenile worms is what is leading to these subcutaneous nodules and swellings. One of the dreaded complications of paragonomus is the cerebral involvement. It can lead to encephalitis, it can lead to brain abscess, it can lead to sudden deaths. So how do you diagnose it? Eosinophilia gives us the first starking feature that we are probably going towards a parasitic disease. However, it is seen only in 20 to 25% of the cases. It is found in the acute and subacute phase, and as we go to the chronic phase, eosinophilia disappears. Microscopy remains the cardinal diagnostic tool. Eggs in the sputum, eggs in stool, eggs in bronchoscopy is what we need to look at. Also, there is intermittent shedding of these eggs. So, consecutive samples, repeated sampling is what is suggested. ELISA is very specific and sensitive. However, the availability is questionable in other parts other than northeast areas. Also, serology in serum and CSF samples is what is suggestive if you're suspecting cerebral paragonomosis. In imaging, we can see multiple cysts, irregular linear lesions, as we saw in this particular patient in the lung, curvineal lesions, and multiple nodular opacities, which are suggestive of the egg clusters. Pleural effusion is very, very common, almost as common as 20 to 60% of the cases. So the treatment of choice is praziquantel, 75 mg per kg per day in 3 divided doses for 3 days. So it is given for all species. However, it has been mostly advocated in children who are more than 15 kgs. This child was barely 10 kg, hence it was a challenge, hence continuous monitoring had to be advocated. Cure rates are almost as high as 100%, and an alternative is triclabendazole, which can also be given for paragonomosis. So in this particular case, he was given a cocktail of antiparasitic drugs. Something did work the previous time, but epidemiological and sanitation techniques are very important to decipher and to counsel the family, which ended up leading to recurrent infections in this poor kid. So we must keep a high index of suspicion in terms of our epidemiological distribution, in terms of behavioral habits, in terms of food habits, travel history, food history, as well as behavioral habits history is something which goes a long way. Eosinophilia gives us a direction towards suspected parasitological diseases, but it is not common in all the patients. Hence, a background of environmental factors is very important. Radiological features are very characteristic for these Trematodes infections. Biopsies, if available, showing charcoal-laden crystals helps us in clinching the diagnosis. The treatment is very simple, treatment is very effective and very easily tolerable. Hence, these diseases are very neglected. One Health approach is what is advocated, where cattle, environment, and humans all need to be, all sectors need to be catered and treated well. Educating the family, educating about good food habits and good sanitation is very, very important. Additionally, veterinary public health measures is something that WHO is planning to take on to take care of these neglected tropical diseases. Thank you. I would like to take questions.
Thank you, Dr. Anivita. Most of these diagnoses on flukes are not made by fluke. It needed actually a very, very elaborate workup on that. I'm somebody who's working in trauma and quite away from the trematodes. But interesting to hear this talk, because many times we put the labels in emergency medicine, like, from Dr. Kavitha's and your talk. It's a very important thing for our department to make sure that there's a close head-to-foot survey of the patient, and something which is a skin lesion. Sometimes we may not be explained because we are not the rash specialists or the nodal specialists many times, because we look at the bigger existence of life. But it's very important that we don't mask this or give this right handover to your departments or give a right time IFT referral if we are suspecting something which is beyond our interpretation. Of course, it goes to the primary specialties or broad specialties as well, because the things what is actually there and what we think it is may be something completely biased because of our own perceptions. And if we are able to transcend this bias, essentially we are going to have a better healthcare, because otherwise the patients have to travel quite a long distance, or sometimes they may not be making their life journey complete. Thank you very much for your great talk. Open to discussion.
No, so it was suggested, but the kid and the family was very, they were very reluctant in going through further investigations. That was the last hope, was just to send a stool and a sputum sample to nearby Zoram Medical College. So it was very interesting to note that how Singhada is a very severe risk factor for fasciola. So much so that my husband himself loves to eat Singhadas, and he would, peel it off with his teeth. So when I was going through case reports, they categorically associated that peeling off with your lips or peeling off with your teeth, the outer layer of Singhada, which is the most contaminated one, is rather the biggest risk factor. Rather than eating the seed, peeling it off with the teeth is the biggest risk factor. So when I told my husband this, he literally told me to go in the other room and let him enjoy his meal. But what we need to understand is that all these water plants which are grown out in the wild, rather than the ones which are cultivated or cultured like in the recent times, are the ones which are at risk. So the ones which are growing in wild, which have animals grazing around, which have a lot of contaminated water, is the major risk factor. These days in the market, we are usually seeing plants which are cultured, which are cultivated in safe environments. However, washing them with good water, and preferably having the cooked form, like yesterday we went out with our friends and we had crispy water chestnut, is a definitive good alternative.
The question is that whenever you look at the CT scan of a fasciola, whether the tracks are more important or the grapes are more?
Grapes. The tracks are very difficult to find in fasciola. For paragonimals, the curvineal tracks are very categorical and very characteristic. But for fasciola, those cystic lesions, grape-like lesions, and biliary tract fibrosis, biliary tract thickening is what is seen. The larval tracts, as we say, is probably an overdiagnosis that is not very easily picked up, and biliary tracts which are dilated are often misinterpreted as larval tracts, but actually the cystic lesions and the perilesional edema is characteristic of fasciola.
Hi, I had a question. So it appears that the child was following the same food practices as probably the neighbors, or if they are, I don't know, he had the other siblings and the rest of the family. So why was only this child being affected? Did he have any underlying condition? Was that evaluated? Or because he's just eating what everyone else around him is eating? So why
ma'am,
is he getting
a very good
repeated?
question and a very, very appropriate question. So the second time that the child ended up developing these symptoms, that is the first thing that came to my mind. One, is the child having some underlying immunosuppression, and how come the rest of the family is doing fine? So I actually urged the whole family to go and give their sputum sample and stool sample, or rather give mass praziquantel to the family. But at this point of time, they had gone in and out of the hospital so much, they were sick and tired, and they just wanted the kid to be fine. But in such cases, the ideal way is to go for mass administration of praziquantel to the whole family, and the whole family needs to change their food habits, not just one particular kid. Thank you.
Yeah, to control this foodborne trematodes transmission, WHO advocates countries to go for national deworming days. Accordingly, Government of India, last 10 to 15 years they are doing it, national deworming days for every 6 months. That means they are giving albendazole tablets to all populations, right, from 2 years onwards. You think that is effective or more specific targeted interventions is required, particularly looking into the background of kind of parasitism in different parts of the region? Is that important, or how effectively these national deworming days are controlling foodborne transmission of trematodes in India?
That's a very good question, sir. So albendazole is basically targeting hookworm and anemia in young female. That is the mass drug administration that they were doing. Recently, government had advocated triple drug deworming programs where they included albendazole, ivermectin, and if I'm not wrong, that also included praziquantel. But
that's what I am asking actually. No, region-wise specifically, no multi-drugs.
Yes, sir.
Because polyparasitism is very common. Diagnosing it's not actually cost-effective thing. Rather than going for safe drugs, combination specific to the region where such infestation is occurring. No, what is your take on?
In the endemic areas, mass drug administration is definitely one of the good approaches. But additionally, as we saw in this particular case, the behavioral habits need to be changed. So mass drug administration is going to take care of the acute illness that is happening, but it's not going to prevent the relapse of the disease. Mammals like the cattle, that is actually the reservoir of this disease, they need to have mass drug administration more importantly as compared to the humans. If the reservoirs, if our intermediate hosts are not devoid of the disease, it's going to keep happening. The cycle doesn't break. So the One Health approach is what advocates the same thing. Animals, humans, and the environment, all three need to be catered at the same time. Otherwise the cycle will never break.
But however, it's going on many of us are not aware. Every 6 months they give, because life cycle of all these organisms is probably 6 months. Before that again another dose that eliminates certain specific parasites. But still there are some organisms left out than the broad spectrum albendazole or mebendazole they are giving. Yeah, another thing, just wanted to know how common is the manifestation of allergic reactions because of loads of worms in that intestines of human body?
For trematodes specifically?
Yeah, yes, ma'am.
So the skin manifestations are in some studies reported in all patients. In some studies they were reported in just 3-4 patients. The studies are actually very scarce. But both the patients that I saw, they had skin manifestations in some form or the other. And in the case reports that I'd seen recently from CMC Vellore, where they had identified patients from Arunachal Pradesh and UP, they also had skin manifestations. So it's what meets the eye. If you're able to see and identify the clinical features, they will surely be there. So certain visceral migrations or hypereosinophilic allergic manifestations are mostly there in the patients. And regarding albendazole, sir, it will never affect trematodes. So if we are targeting trematodes specifically, albendazole is not going to work.
Yeah,
the drug of choice will have to be either triclopendazole or praziquantel.
Okay. Now, otherwise, clinicians routinely giving such drugs specific for the target without going for so much of investigation. I'm just thinking about the cost benefit effect, particularly low socioeconomic populations, how it works. Now, awareness among the treating doctors, treat such populations with the once in 6 months, that kind of drugs administration specifically.
It's easy to administer albendazole 6 monthly, and it's often a routine practice, but it misses the trematodes. So administering praziquantel or triclopendazole 6 monthly without any clinical epidemiological evidence would not be a prudent choice. But yes, in endemic areas where you're suspecting because of behavioral habits, it might be a good way to go about it. But I think it's open to discussion. I cannot be alone advocating such things.
Okay. Yeah. Thank you, sir. Yeah, yes, sir.
This prophylactic prosecutor, if it is given somebody with harboring neurocystic fibrosis, will it cause harm? This prophylactic praziquantel, somebody having asymptomatic neurocysticercosis. So when you give praziquantel, I believe that you have to give, if it is a diagnosed neurocysticercosis, along with steroids. So if you give indiscriminately, will it cause harm to those people who are harboring neurocysticercosis or any other
So,
vital
sir,
organs?
this is going to be a trematodes course of praziquantel for the trematodes versus the routine dosing for neurocysticercosis. But it's a quite an interesting question. I'll have to look into it. I'm not aware if such cases have been reported. Theoretically, it should be causing harm. Yes, 3 doses are good enough to cause a lot of perilesional edema and maybe can throw a seizure. But
even because he raised that issue, I got the doubt. And as far
Now,
as
in public health, they are planning, they look at larger population benefit than individual few cases. You rightly said, sir, probably that will mask the symptom of meningitis and may worsen it later and further complicate. That is true. But that comes clinical management of the cases. But planning for the nation, programs, probably they look into the larger benefit of the population, sir.
As far as Dr. Aggrawal's presentation, one important point, we clinicians usually do not think, we get a lot of eosinophilias. We simply give one albendazole, maybe 1 or 2 investigations. I never thought of going for stool examination, looking for these rare diseases. Thank you for that information.
thank you, sir.
Thank you, madam, for presenting beautifully about that neglected disease. But you people, we tend to ignore that disease, particularly in animals and human beings. But prevalence is very high, and it has got its consequences on particularly low socioeconomic population, child growth, development, and education, all that related to that disease. Thank you, madam. Thank you for your wonderful presentations.
It's a pleasure to introduce Dr. Chandni R, Professor of Medicine and Head of the Department of Emergency Medicine, Calicut Medical College from Kerala. She is the recipient of the Best Doctor Award 2018 from Government of Kerala, and she is received the Best Teacher Award from Kerala University of Health Science in 2019. She is also a National API Master Teacher 2021, and she is a member of Board of Studies, Medical PG, and Faculty of Medicine at KUHS. She is a nodal officer and state medical board chairperson for the Nipah outbreak in Kerala, and she is the state expert committee member and state medical board chairperson for COVID. She has a number of publications. And ma'am, welcome to deliver this talk.
Indeed, I am privileged and honored to stand before you in this prestigious conference. I am thankful to Dr. Kavitha Saravu for inviting me in this one of the premier institutions, teaching institutions in India. And that too after Anivita's talk. I was really enjoying the way she describing the life cycle of Paragonimus. She is enjoying and she make us also feel so. It was a very wonderful presentation. And I'll be taking you through Nipah virus in Kerala. Each outbreak is a concern as it is allowing the pathogen to modify itself. So the lesson that we have learned from COVID-19. So when we talk of Nipah, I think we cannot move without remembering the sacrifice of healthcare workers throughout in COVID-19 and Nipah. And in Nipah, we especially remember Sister Lini and all those healthcare workers in 2018 were willing to work even after Lini's death in front of those who are in the outbreak management team. So I'll be discussing about Nipah virus, outbreaks in Kerala, new learnings and transformation in care, way forward and One Health approach, everything in the allocated 25 minutes. And my disclosures are it's a personalized edition rather than a textbook edition, so I'll be living through the experiences because fortunately or unfortunately, I've been part of all the outbreaks of Kerala, managing this. And we have the Nipah virus infection treatment guidelines of September 2023 available at the website of Directorate of Health Services. It will give how we do the management protocol, testing, contact tracing, everything is included in that. So if those who are interested can really go and check that as well. And there are very many publications related to Nipah. Outbreaks were happening, so definitely we will have some of them documented. So we all know that WHO 2021, the priority diseases, COVID-19 is already included, and disease X is still there. Bats are having so many viruses, and we are still waiting for new to come. And one among them are Nipah and Nipah virus diseases. Nipah virus in India, this is the 6th outbreak since 2001. First was in Siliguri, second in Nadia, third happened in Kozhikode in 2018. There were 23 cases, 18 confirmed and 5 probable, with a case fatality rate of 91%. There was one spillover infection in Ernakulam, Kerala in 2019. One case, a patient survived. Fifth happened in Kozhikode in 2021. One case with that patient succumbed to the illness. And the most recent one is in 2023. 6 cases with 33.33% fatality. So outbreaks are not unusual. Zoonotic outbreak, when with high human-to-human transmission and high mortality, that is the challenge that we have to be prepared for. This is for Nipah, but it could be for any of the similar outbreaks that may come in the near of our future. NIV infection it's an RNA virus, Paramyxoviridae family, genus Nipah virus. And incubation period is varying, but roughly it is 4 to 14 days. And fruit bats are responsible for transmitting the infection or transferring the infection to human beings. And the presentations, encephalitis, ARDS, and myocarditis. Myocarditis was also reported from 2018 outbreak, because we were doing some of the point of care ultrasounds. Maybe it has been there even in the previous outbreaks as well. And the major challenge was we have to have specific laboratory facilities, infection control practices, isolation and intense supportive care. Everything is challenging in full PPE and with the limited resource settings. That was the situation in 2018. So this is the way we move forward. 2018 and 2023 were real outbreaks. 2019 and 2021 were spillover infections. That's the way we have been moved. And 2021 was all the more challenging because it happened during COVID-19, where even the COVID-19 pandemic we were struggling to handle, and that time we had to have this Nipah as well. So I would like to look at it at 2018, 2019 is before COVID-19, 2021 through COVID, and 2023 after COVID-19, because 2018 has given us a lot of lessons for managing COVID-19, but COVID-19 has made us more prepared for managing 2023 infection of Nipah. So in 2018, the story began as one patient, 26-year-old male, came with high-grade fever, headache, vomiting, altered sensorium, febrile, drowsy, tachypneic. He was managed in the busy emergency department, which was having a total of 510 patients. Half of them got admitted, so it was too busy. And the patient was identified to having ARDS and encephalitis, and has managed as the way we used to. And patient expired on the same date, and the diagnosis was viral encephalitis. We know that we are not in a position to identify the cause of virus causing the infection. In most of the situations, 30 to 40% we may be able to have a diagnosis at that point of time. Now, with more tests, we may be able to give the diagnosis in most cases. But at that time, I just looked at what is happening with viral encephalitis. In 2017, we had 134 cases, 19 deaths. There was no Japanese encephalitis reported at that point of time. And in 2018, we had 154 cases, 20 deaths. Of these, 5 were Japanese encephalitis, and we had 12 confirmed cases of Nipah. That was the data we could collect in 2017 and 2018. So after this patient came on 5th May, again on 17th May, 3 of his family members got admitted, but along with that, 32-year-old female from a nearby district admitted with ARDS and myocarditis. At that point, the system got alerted, and on 18/5/2018, there was a report from Manipal. That's why I have more closely associated Manipal Center for Virology and Research Institute. Still I remember Dr. Arun Kumar, Dr. Anu, Dr. Jasil, all of them were with us because they were behaving as if closely associated friends of Calicut Medical College. And every evening they were there in the outside the Nipah isolation facility when most of the people were afraid to travel to Calicut. So I really I take this opportunity. We never got an opportunity to thank Manipal Center for Virology Research Institute. Now the name had changed. And I'm very thankful because they were actually behaving as one among ourselves. And every evening when we used to call Arun Kumar, maybe hardly 2, 3, 4, 5 times whenever we wanted an help. And every time we feel so much relieved when they are there to receive the sample, and sample were actually being transferred here. And when there was one flood, we had got a problem in getting the research, so that was all there. And I take this opportunity to thank this great institution for that as well. So after that, National Institute of Virology confirms the results on 20th, and the outbreak was officially declared in Kerala. But before the outbreak was declared from 2018 itself, when we have given the clue that there is a dangerous infection, the system was actually activated to tackle this outbreak. So this was very new to have an infection with full PPE, and that too with lot of things that we need to change. The practice as a clinician, we had to change at that point of time. So we have to have infection control practices, personal protective equipments, housekeeping practices needed to be changed, the health of the staff needed to be monitored, visitor policy to be changed, handling of samples and handling of the disease, everything has to be changed all on a sudden at one single point, and it was really a practice change at that point of time with management of Nipah infection in 2018. So we had to improve, we had to have protocols, we had to have guidelines on case identification, lab confirmation, case management, risk communication, contact tracing, quarantine and isolation every time. In 2018, we had so many committees, and it has to be meeting in district collectors of chamber, and all the committees were having different responsibilities that has been set, including psychosocial well-being of the patient, family, public, as well as the healthcare workers. So what we had was, we had 1 index case, 18 confirmed case, 12 males, 7 females, and maybe 4 probable, taking at the history and management at that point of time. Clinical presentations, as I have highlighted, encephalitis, ARDS or myocarditis. One patient has only something like an upper respiratory infection, fever, headache, tiredness, cervical adenopathy. We had 2 survivors with different spectrum. One patient had myocarditis, encephalitis, ARDS and dysautonomia. The other patient was having simple flu-like symptoms. And then the outbreak 2019, it has also happened in May. One patient, it's not an outbreak, it's a spillover infection. One patient, 20-year-old male, fever, headache. It was an encephalitis-like presentation. That time also contact tracing, risk assessment, management, everything has happened. All those contact people with infection were shifted to the department, and they shifted to the hospital. They were kept in single room facility, and that's been actually managed till we rule out Nipah infection. System got promptly alerted as we did in 2018. So there was a need for preparedness as well as research in medical emergency. I felt that was a major need because giving any drug in that situation is very difficult. And all the clinicians will be actually involved in patient management day in and day out. We will be really exhausted and tired. But we have to have protocol identified, all ethical committee approvals obtained, and we have to have the team constituted. Everything has to be done in place when we really want to do a research in medical emergency, because we may not have any new drug at that point of time when a new infection comes. Then moving on to 2021, it was a 12-year-old male. He also had features suggestive of encephalitis, and he was having refractory seizures. He had chest X-ray which showed infiltrate, CT showed brain edema, point of care ultrasound was normal, MRI showed some features suggestive of In flare, hyperintensities in subcortical and brainstem. There was myocardial dysfunction later, and he was on inotrope support, and diagnosis was made, and patient succumbed to the illness. In 2023, that is the very recent one, in August, September, 6 confirmed cases, 2 deaths. We have 4 survivors. 2 were having only mild symptoms, and 3 were presented with ARDS. Those who have succumbed were having actually ARDS, and 2 survivors were having encephalitis. 1 patient was having, the child was having ARDS as well as encephalitis. So the problem is, I'm really scared to talk about community medicine because the HOD is sitting here. But the problem actually comes is primary case and index case. Even I was not very sure about all this epidemiological assessment and management. So most of the time we use synonymously is the primary case and index case. But in the first epidemic, first outbreak in 2018, we had 1 patient from Malappuram and another 3 from Calicut. So we were having a real doubt whether it is the primary case that we have identified, it is the index case, because primary case may be the case that actually transmitted the infection, but the index case is the one that we detect as the first case. So we have to have a lot of work in that also. There is a lot of work will be done by the community medicine colleagues at that point of time to help us. And how to suspect geographical location. And both of the infections in 2018 and 2023, when it has happened as an outbreak, there was hospital clustering, or the outbreaks actually propagated from the hospital. So we have to look for family clustering, hospital clustering, and we never asked for hospital visit. We were asking whether there is any previous hospital admissions. But diseases like Nipah, family clustering and hospital clustering is very important. And we know that people travel a lot. By the time we find out the family clustering and we started to manage the contacts, they might have traveled internationally. So it is very difficult to tackle them and keep them in-house to find out. And the other important point is when a patient with encephalitis comes with refractory seizures, autonomic instability, this might trigger a clue if we are actually in the geographical location. And other features were diplopia, unsteadiness, nystagmus, ataxia, segmental myoclonus, altered mental state, and combinations of these syndromes like ARDS and encephalitis in an outbreak situation. All of them will have to undergo these tests. So the challenges were we were never bothered to ask for previous hospital visits. Now it's going to be very important in outbreak situation. And the second challenge was turnaround time. I have already told we were actually dependent on this institution for getting the results. So there was a delay which was unavoidable. So if you want to make decisions faster, because this patient is with encephalitis, we have to decide whether it is Nipah or not, or we have to treat for other treatable causes, because other laboratory works also will be pending if we do not rule out Nipah. And lab safety of our own colleagues working in the laboratory, ICP, and uniform standard of care when we are actually practicing with PPE, it is also challenging. Intubation and all other resuscitation procedures will be challenging. And safe burial in a dignified manner, that was creating a lot of confusion, and psychosocial problems related to, and long-term follow-up. Diagnosis, we know it is by RT-PCR in throat swab, by VTM, endotracheal aspirate, saliva, it's actually throat swab, and blood, urine, CSF if we do a CSF testing. And in 2019, we had the point of care PCR assay through National Institute of Virology for NIV detection by TrueNat test, and then the viral genome sequencing for phylogenetic analysis, antibody estimation. And we have to be very, very careful about these syndromic presentations and the approach. And the WHO has come up with a definition of acute encephalitis syndrome, case definition of suspected case, acute onset of fever, not more than 5 to 7 days duration, change in mental status with or without other features associated with encephalitis. And when this Nipah came, We also had a problem because some of these will not actually including the Nipah, because Nipah might come with ARDS. And the other point, when somebody was asking for stool examination, when a patient comes with encephalitis, we were routinely doing throat swab or endotracheal aspirate. So that is one thing that we have to, because there is a maximum chance of detection of the virus is by the examination of throat swab or nasopharyngeal swab or bronchial wash or endotracheal aspirate. So patient of acute encephalitis syndrome presenting with one of the following, that is respiratory involvement, myocarditis, autonomic dysfunction, myoclonus, white matter lesions in brain and spinal cord and MRI, or with a similar history or family clustering, hospital clustering in the past 3 months, we have to think of diseases like Nipah. And neuroimaging and EAG will give different types of presentations or pictures, and definitely our radiodiagnosis colleagues might give us clues with regard to Nipah as well, because of the focal, subcortical and deep matter white and grey matter lesions, small hyperintense lesions in the white matter cortex, pons and cerebral peduncles, but these are not very specific, but these are most usually described. So why there is encephalitis more common in Nipah? Because we see the characteristic MRI abnormalities. It could be due to necrotizing vasculitis and syncytia formation, vasculitis induced thrombosis, or it could be due to direct neuronal invasion. And we need to have more data to say why it is so. So when this outbreak happened, ICMR is actually having an algorithm for acute encephalitis in India, but ICMR again looked into for revising this, for including Nipah, because JE they have included in places where there is high suspicion, Chantipura in their location, but we cannot do Nipah in every acute encephalitis syndrome. So in Kerala, they have put this as patients with fever and altered sensorium with or without seizures, and they have recommended a 2-tier testing strategy at the district level as well as at the regional referral laboratory for early identification, testing and management. But this could not be incorporated because Nipah IgM is not freely available, and most of the tests are available and restricted to certain laboratories. So this was the testing algorithm proposed, but since Nipah IgM is not available, we may not be able to do this at the district level for ruling out Nipah. So all the cases are to be referred to a tertiary care center if it is suspected, or samples are to be safely transported for getting the results. So this is the testing algorithm at Apex or regional referral lab. We will look for bacteria PCR, Nipah TrueNat and all other suspected entities, as well as we go for the serology of Nipah, especially Nipah IgM. The problem with this is if we suspect any other disease but we suspect Nipah as well, we have to rule out Nipah first and then go for other tests. So this is about the case definition. As this is in any other disease, when we have a suspect in the locality with similar disease and patient presenting with encephalitis, ARDS and myocarditis, probable patient has similar features but died before we could establish the diagnosis, but there is a definite history of contact with the deceased or with the patient. And third, the confirmed, definitely we have the confirmatory test. And definition of contact listing is also very important in Nipah. So close contact is defined as a patient or a person who came in contact with a Nipah case, and we have any of this contact. It could be hospital, close contact, patient management, transportation, or it could be handling body fluids, or he has touched or clothes or linens, or he has done some rituals of the deceased. So all these will come under the contact list, and in fact they will be listing them as high risk and low risk. But for clinicians, whether the patient is in high risk or low risk, patient develops symptoms means patient has to be transported to a facility with single room and washrooms available. And the first and foremost thing is we test for Nipah, rule out Nipah, and then go for other testing. Or if we have a strong suspicion and patient is continued to have symptoms, we need to repeat testing because one test may be negative, but it still could be possible. And other important challenge most of the time is triaging of the patient, because patient will be coming to the same emergency department with fever. So now we are all very familiar with managing fever as fever triage, where we have to ensure strict infection control practices, but infection control practices are to be followed everywhere. Crowding has to be restricted because transmission happen in crowded hospital wards or emergency departments. So this was the triage protocol all of us were following during COVID. We have a COVID triage as well as usual ED triage, fever, and we will be shifting patients to COVID triage because there is a pre-triage option as well. But I put it because it was running 3 parallel triaging with lot of resources and crunches, and that was the major challenge that we had during Nipah. When Nipah came, we had to do this. And we had to have proper signage boards. So because patient with Nipah should not go to the emergency department, other patient diseases. So this is also a challenge that we may have to face. So the system has to be well oiled and ready to be implemented. And the management, we have to put the investigation panel, should include a well taken throat swab and nasal swab. This is very, very important, and any encephalitis, it will be a helpful clue if you go with a well taken throat swab. Primary adjuncts are to be used like point of care ultrasound, ABG, ECG, bedside X-ray, labs, because other investigations like shifting a patient to an radio diagnosis room may be difficult, but all this will give us definite clues how to manage this patient. And the other thing that has happened, as I told in 2019, on-site field NIV diagnostic facility by the TrueNat PCR, where we can get the result within faster as we get the TrueNat in COVID. Then 2023, in fact, the mobile BSL-3 of NIV has actually kept in our campus, so that was a major boost. We get results much, much faster. And what more major change that has happened in 2023 was we could establish a fully automated biochemistry analyzer, because these patients were actually deprived of other tests and investigations because they come with other diseases as well. So we need to manage well, otherwise the mortality will definitely increase. So all this has to be kept in place, and the systems has to be well tuned, because the system has to be so oiled. So we have to be ready to receive these cases. Never do away with universal precautions. High risk procedures. I always tell my postgraduates, use a face shield when you go for intubation, suction, bronchoscopy, nebulization. So after going through COVID, I think we have to have this practice of using a face shield and full gown and not the full PPE. This will save us, and this will reduce the restriction of human resources, because when an outbreak happens and the contact list is prepared, all the working force will be in quarantine. So this is one major challenge. So we have to have a continuous training. Management, I will just briefly go through. We have to have intensive supportive care, because we don't have any drug or vaccine for Nipah. Maybe because India is so much prepared for indigenous monoclonal antibodies, and we hope before the next outbreak we will think from India. Specific treatment, no therapeutics, but all the antivirals. 2018, ribavirin was started on confirmation of Nipah viral disease. 2023, remdesivir was given to the patients, and monoclonal antibody considered on compassionate grounds. So we have to have protocol, consent forms, everything kept ready. And it will be coming in -80, so thawing and administering is all a major challenge in a PPE restricted entry areas. Remdesivir, we all know, we have used well in COVID-19. Dose is 200 day 1, 100 milligram for next 12 days. Post-exposure prophylaxis also advised in the same dose, but I'm not sure. I don't think any of them have used, but I don't know whether any healthcare worker has used remdesivir as a PEP. And favipiravir is also can be used in post-exposure prophylaxis. Ribavirin was the drug that we used because there was data that Malaysian outbreak open label trial. There is a 36% reduction in mortality, but patient has to consume 150 capsule because the capsule comes as 200 milligrams. So we have to counsel them because they will be too much worried about taking so many capsules. And we have given empirically tried in 6 patients in 2018. monoclonal antibody, it inhibits entry through the epherin B2 receptor, the viral entry inhibitor to epherin 2 receptor, and thereby it inhibits viral entry. So this was brought all the times. Whenever an outbreak, it is there, but it is now in NIV. So we used to get this drug in our place, and our clinical team will be alerted about a possible compassionate use of this. So we have to have SOP guidelines and the consent forms. So this is the protocol or Nipah treatment algorithm in 2023. So this includes everything. It might be a crowded slide, but it is available at the Directorate of Health Services site. So if you really want to see how we did, you can go through. It includes all these drugs, as well as whenever a patient comes with an infection with definite history of contact, we need to rule out Nipah. And if we are sure that there is a definite alternative diagnosis, we can go for management. We don't think it is no other alternative diagnosis made, we will be repeating the test so that we could rule out the Nipah by 2 tests. And discharge plan is also if the patient is clinically stable, the clinician agrees on discharge, and 2 tests on a period of 5 days apart were tested negative, patient were discharged. So this is the action plan. High index of suspicion, appropriate lab test, declaration of outbreak, line listing, shifting of symptomatic to isolation facility, quarantine for 21 days. So this is also a huge task. Psychosocial support, because I remember during COVID-19 when some of the medical students were kept in quarantine, one of the students called me, "Madam, I can be in a room for any days, locked from inside. If I am locked from outside, I can't even stay for 1 minute." So quarantine is not that easy, and people may not obey to what we say because it is very, very difficult. Many movies and short stories has come after this quarantine stories. And daily review planning, source identification, batch survey, which I have not touched because we don't have time. False messages, transparency of communication, and support to families, because it is a stigma even today. And healthcare providers also need support. They should be monitored for fever, tiredness, vomiting, self-reporting, and every time they should be looked after well, and they should be appropriately cared for, because this is all the more important because we lost 1 life for Nipah. And documentation of fever and monitor them if they have a fever for next 21 days. Deceased management was also a major challenge. And psychosocial impacts were tremendous. We have actually seen in those patients, those kept in isolation during 2018 outbreak, as well as we have talked to those as a qualitative study, all those were giving very painful messages. So we have to emphasize on this for Nipah or similar outbreaks. And long-term sequelae is also reported. So we have the commitment to follow up these patients, and they also should be told that they may have some symptoms they need to report, but we need not panic them to that extent as well. So to conclude, what we need is teamwork, and what we need is preparedness. This is all about Nipah outbreaks that we have gone through in Kerala. Usual and unusual presentations of an uncommon illness with the potential to spread to healthcare providers and close contacts. So that is the major challenge that we are still facing. So healthcare workers are also at risk in this sort of infection, which we have seen in COVID-19 and Nipah as well. So we have to adhere to infection control practices always. All our junior colleagues, you are actually handling or managing patients with lot of secretions, fluids, intubation, Rayleigh tube aspiration, Rayleigh tube suction, throat suction, all these procedures, nebulization. My request is use minimum protective equipments and use a face shield when you go for intubation. A lone fight cannot stop a biological disaster, so we need to work together, and there comes the importance of One Health. I have not covered. There are many people work together with BAT and other things, a totally different story. And every time we have lot of people, lot of publications, but ultimately together is the message. And thank you for the great opportunity.
Thank you very much, madam. So the three deliberations today from Dr. Kavitha and Dr. Anivita and now Dr. Chandni is all pointing to one thing, that is about One Health. So we have seen that something which is seasonally present and one is very occasionally present, and now something is dreaded to be present at any point of time. And these are all possibilities what we have been seeing today. So madam, coming to your talk, we have this problem of vigilance fatigue, starting from pre-hospital to emergency medicine settings. I'm very passionate and possessive about that. So whatever I'm talking, I'll be coming to emergency medicine. So how do we deal with the vigilance fatigue in an emergency medicine department which you are heading? Because you can have, apart from the common pandemic problem, you can have the specific Nipah outbreak or scare at any point of time, because it is proven to be out there in the bad population. So how do you deal with this issue, and how are you managing it on a daily basis in an operational way?
And you are asking about healthcare worker fatigue or the...
Yeah, healthcare fatigue. System fatigue will be, that's a normal.
Healthcare
People
fatigue,
have to go back to their normal life.
I think it is there.
Vigilance, I'm talking about the vigilance fatigue. Like, we are tuned to and we are hyper-tuned to. Afterwards, we'll be in denial.
We will miss many of the things because that's why emergency always goes like ABCD and protocol base. We are likely to miss. But things that we can do is, in our emergency department, we fail to control the crowd. And secondly, we don't know when this outbreak will come. And even for COVID-19, I don't think many of us would have thought that COVID-19 will be a problem for India when it all happened from China. But the next day, they directly came to Kerala from Wuhan. So this will happen. And when that contact history was taken for COVID-19, I was thinking in Malappuram only people go to Middle East. But when contact history was taken and the places from people came, even the smallest islands, people are there in our place. So this is, any infection can come. But only thing that we will be tuned to is we should look for that syndromic-like presentations. And some of the things like refractory seizures, which is little bit unusual, or myoclonic jerks, autonomic instability. We were also afraid when the BP goes to 200 and 100, then next time it comes to 80/60. We are very much worried. And one clue is encephalitis patient. We may be looking for neck stiffness, but nystagmus. All these clues. But how can we shift a patient to isolation when we don't have any previous information? But what we can do is, if we have any such suspicion, at least restrict their movement. So I cannot say that we will be doing every encephalitis with Nipah, even in Calicut, because Nipah will be missed, because presentations may be different. Altered mental state, we will be doing hypoglycemia and all other metabolic parameters. But the fever may be subtle or they may not come up. So those situations can happen. But what major thing will be, you should have the intense supportive care. And one thing I always emphasize, try to get a blood culture at the earliest possible before we embark on too many antibiotics and all sort of drug into the patient. And third thing is, I will always emphasize that go for strict infection control practices, at least in such difficult procedures. But I'm sad to say, even mask is actually going away now. We cannot use mask in every places, but in these places we should be more careful. And unusual, it's always a curiosity, and some residents should go after them. That is the other thing. Sometimes residents go after them and they come up with clues and suspicions. But infections usually do not wait. It's very challenging, and healthcare fatigue is also a major challenge in emergency department. So there is a limit for asking them to do all those things. We tell them, but there may be misses always.
Also, has any part of the practice, apart from the setting the laboratory, diagnostic facilities, have our regular daily routine care practice changed in any way because Nipah came or COVID came?
I don't think, because it is emphasized every time. I don't think anyone is using mask when we see patient in an OPD. Very rarely an elderly person who has really suffered COVID-19 or who has really motivated to use mask. Most of the time mask will be here. most of the photographs, even doctors will be, our senior doctors will be wearing mask here. So I will request them, either you wear properly or you don't wear, because this is giving a very wrong message to the public. And most of the postgraduate student in strike, mask will be here. So that we are giving a very wrong message. Mask is really protecting, but very reluctant. And I feel face shield should be used. All difficult procedures where there is lot of aerosol generating.
Audience, any questions or any interpretations?
What will be your message for the other states who had not had Nipah outbreak till now about going about?
So the bat survey has shown, bat survey has done from West Orissa, and I think from Andhra, Puducherry, all these places. So Karnataka, Kerala, Puducherry, Tamil Nadu, I think, the bat belt is there. All bats are having Nipah. So why Calicut? That is the question that we are trying to answer, or the world is trying to answer. Why every time Calicut is being affected, we don't know. If there is any way we can identify, but definitely bats are there. Such encephalitis also might be happening, as our isolated cases might be happening, which we might have missed in the past, and somebody else also might be missing, because we don't do Nipah routinely. The third message is for clinicians, if you see some of these unusual findings, every time I talk, they say, oh, this is something atypical, this is not the usual encephalitis. Clinicians usually comment, so all those things we have to do. Or you can do a battery of tests. That is happening everywhere. We can do a full battery of tests. You might pick up Nipah, and that will create a lot of anxiety. But these are those spillover infections will be there. But always ask for family clustering, hospital visits, and or any of your neighbors having similar features. This might give us a clue to suspect Nipah. And encephalitis, if we really suspect, we have to get a throat swab. Or a patient endotracheal intubated or endotracheal aspirate, so send a swab also as well along with this. The major challenge is, if we really suspect, it goes on us to rule out Nipah before sending all the samples to all over the world for other tests, because it's going to be on our responsibility to save our colleagues, laboratory people, everyone. So if we are suspecting, now facilities are available and we can get the test done very fast, but we may have to support with our other things like antibiotic, antiviral, everything we routinely do in those patients where we don't have a diagnosis and patient may not be alive for next 24 hours. So maybe we can do in single room, or if you can keep in negative pressure if available, and do all the tests, but the patient management also should not be delayed just for waiting Nipah. So it's a balance. And when Nipah happens in 2018, 2019, all the years when Nipah happened in Kerala, I used to get calls from all across India, this could be Nipah. Because we see similar presentations for many other conditions. So it is a challenge.
Anybody else? Okay. Thank you, madam. We want to salute you for your great work in controlling, containing Nipah, Kerala, thereby preventing it further spread. Few epidemics. It's like a soldier protecting nations. I just wanted to know, you faced the first epidemic and second and third. What challenges and advantages you had in containing the disease in second and third outbreaks? What challenges still persisting? What is your advice?
Every time, 2018, I told there were a lot of challenges. In fact, patients were waiting for Nipah result, and we know that we need to do many other things for them, which we might have failed in, like hypoglycemia may be there, so patient has to come with their own glucometer, and we were also not having many PPEs where they were not that good quality, because everything started all on a sudden. PPEs were not available at that point of time even to purchase. But the important challenges were we don't have a point of care lab, not only for Nipah, but for the other tests as well. Okay. And there was a turnaround time. Getting the results were very much delayed, and system was not tuned to. Clinician is never bothered about contact listing, contact tracing, and all sorts of things. And our community medicine colleague is always very angry for not giving the details of the patient correctly, because so that sort of things were happening. But we learned that epidemic is different, case management is different. So those lot of lessons we have learned with the first outbreak. And the protocol were in place, monoclonal antibody, how to do on compassionate ground, how to prepare the clinical team, everything were in place. So in the second, one thing we requested was we want faster results. So that was happened in 2019 as the point of care lab, TrueNat test came. And 2023, in fact, we had a lab set up for other tests. Full facility lab was set so that we can do all the biochemical tests and other things. And to get real success in these sort of situations, the district administration, our district health system, and the community medicine department, clinician, pediatrician, gynecologist, everyone should be on the same boat, and we have to work together. And a critical care team will always help in managing difficult challenges. So the important lesson and important learning will be everyone has got a big role to play. And if one person is not doing it right, it will be very difficult. And I have told, we have 18 committees, including media, management, psychosocial work, contact tracing, and even for people visiting NIV and NICD or world different organizations will be coming in to see this. We have one committee for, so otherwise the system will be collapsing. Everything will go into this. So that sort of, all these were learning, and there are many gaps still existing, but I don't want to learn again and again because it is also tiring.
Basically, it is teamwork, fantastic teamwork, madam. Again, thank you for that, and not only for that, and coming and sharing your experience here for our PG's faculty. And
special thanks to Manipal for that brilliant contribution and support at that point of time. Thank you.
Thank you, madam, so much.
Thank you so much to all the speakers and chairperson for such an insightful and interactive session.